This is a collection of edited videos showing nuances of performing a crossover in Etep-Rs repair. I am Dr. Ganesh Shenoy from Kaveri Hospitals, Bangalore. Hi friends, greetings from Hernias Institute of Training, Kaveri Hospitals, Bangalore. Etep-Rs for primary ventral hernia or incisional hernia has gained increased popularity among surgeons worldwide. The three key steps in Etep-Rs are achieving a crossover, then the posterior closure, then the anterior closure. Crossover is one of the most important initial steps after the space creation to accomplish a Etep-Rs. Crossover is nothing but developing connection. This video demonstrates performing crossover in different case scenarios. We have crossover in a primary ventral hernia, then crossover being performed in difficult situations, like for example, a patient having an upper abdominal scar, for patients who have undergone previous ipom repair, the challenges which are faced when there is a previous intraperitoneal mesh, trachus and transfacial sutures, crossover when there is an early pneumoperitoneum, and in crossover when you have a short falciform ligament. We have given a lot of tips and tricks to achieve a safe crossover in case of Etep-Rs procedure. We have also published our work regarding Etep-Rs in various national and international journals. We feel this video of nearly 30 minutes will definitely help you to achieve a safe crossover when you perform a Etep-Rs procedure for a simple as well as for the most difficult cases. Here we go. After defining the left retrorectus space by blunt telescopic dissection and ports are placed, all the fibrofatty tissue is clear to define the seam or the junction of left PRS with the linea alba. The left posterior rectus sheath is depressed with the grasper, and then the PRS is incised or divided 5 mm from its junction to linea alba. We normally dissect it or divide it till the defect. Then the dissection is carried out staying more on the roof so that the falciform ligament and the preperitoneal fat is depressed down. You can see that the left hand grasper is depressing the preperitoneal fat and the falciform ligament down. We have used 3 lateral ports to accomplish this crossover. Those are the crisscross fibers of linea alba. You can see the twitchings of the rectus muscle from the translucent PRS. Then the right posterior rectus sheath is divided again 5 mm from its junction to linea alba to define the right retrorectus space. In this way, we have connected the left retrorectus space and the right retrorectus space via a bridge called as preperitoneal space and the falciform ligament. This is the completed crossover. Similarly, in robotic Etep-Rs, we place one 12 mm port as the camera and two 8 mm port. The space is created by blunt telescopic dissection. The patient was placed 20° head and down position. Similarly, the left PRS was divided 5 mm from its junction to linea alba after clearing all the fibrofatty tissues and defining the seam of left PRS with the linea alba. The falciform ligament and the preperitoneal fat was depressed down. That is the marshmallow sign, where you can see the pink rectus fibers through the translucent right PRS. The right PRS is again incised 5 mm from its junction to linea alba to connect with the right retroractus space. The neurovascular bundles are to be preserved. Neurovascular bundles are the point where we stop the dissection. Those are the neurovascular bundles. So in this way, through robotic platform, we have connected the left and the right retroractus spaces. Now this is a technique to do a reproducible crossover for beginners. We have placed a 10 mm port in the left hypochondrium in the retroractus space. Similarly, another 10 mm port is placed in the right hypochondrium in the retroractus space. Now, by blunt telescopic dissection, the left retroractus space is created. We use the 30-degree scope for the creation of the space as well as for the entire procedure. Then you also create retroractus space on the right side through the right hypochondriac port. In this way, you have already created two retroractus spaces. Then a 5 mm port is placed around 3 cm above and just medial to the linea semilunaris. Then after dividing the left PRS, you move the port which is there in the right hypochondrium so that it acts as a GPS or a guide and helps us where to incise the right posterior rectus sheath. This is another technique of a reproducible crossover. After creation of the left retroractus space and placing a 5 mm port in left sides, right retroractus space was created. Then through the 5 mm scope, the camera was placed, and then the camera now is shifted to the 5 mm lumbar port, and the left posterior rectus sheath is divided 5 mm from the junction to left PR. That's the linea alba, the crisscross fibers. That's the prepaternal space. Now the 10 mm port in the right hypochondrium, which acts as a guide and enables us to divide the right posterior rectus sheath, is visualized. This is one of the simplest way of achieving a crossover where you can't make mistakes. It is especially helpful for beginners. The steps of standard crossover include defining the seam of left PRS with the linea alba after dissecting all the fibrofatty tissues. Second, dividing the left PRS just 5 mm from its junction to linea alba. Third, divide PRS up to the hernial defect will help to push the falciform ligament down. Now, after we see the right posterior rectus sheath, the rectus muscle can be judged by its twitching. Then you can always place another pre-placed port as defined by the reproducible crossover. Then by the marshmallow sign, where you can see the translucent rectus muscle fibers through the PRS. Then you divide the right PRS to visualize the right rectus muscle fibers which are vertical oriented. Then you divide the right PRS parallel to the cut left PRS to define the right retroractus space. Now we have connected the two retroractus spaces and the prepaternal spaces together, thus completing crossover. There are some instances of difficult crossover, especially when you have early pneumoperitoneum during space creation or port placements or incising the left posterior rectus sheath. In patients who have previous scars, patients who have undergone previous IPOM plus repair, patients who have divarication of recti, and also a small or short falciform ligament. This is one of the cases where we encountered early pneumoperitoneum during a space creation in an obese lady with BMI of 42. Once there is a pneumoperitoneum, honestly the varus needle in such procedures won't help. The key here is to continue the space creation, to create an enhanced space. A 5 mm port was placed in the left lumbar region, but we are not sure of the entry. Then the primary port was removed, and by palpation with the fingers we could place the left 5 mm port in the retrorector space, which was confirmed by replacing the primary or the camera port. Now, since we have one 5 mm port, one grasper was placed in the left lumbar 5 mm port to depress the left posterior rectus sheath. Then under vision, another 5 mm port was placed in the left hypochondrium, and then the left PRS was incised. This is another case of early pneumoperitoneum. We placed a 5 mm port through which the hook was used. We continued to create the space because enhanced space creation here was the key. Here you can see the left hand grasper was not depressing the preperitoneal space or the falciform ligament. This patient had a divarication of recti which was not judged perioperatively. Those are the crisscross fibers of linea alba, and by mistake the linea alba was breached. That's the subcutaneous tissue which you can see. In such cases, what you can do is you continue dividing the left posterior rectus sheath to create an enhanced space, and you visualize the light PRS intraperitoneally. After intraperitoneal visualization, you get an idea where the right posterior rectus sheath is. In this way, you can achieve efficient crossover. This is another case where we encounter pneumoperitoneum while passing the first secondary port. You can see that the port was intraperitoneal, resulting in pneumoperitoneum. We immediately passed a grasper through the 5 mm port to depress the left posterior rectus sheath. Then another 5 mm port was placed in the left hypochondrium. This is what we call like a railroading technique. We used two graspers in the two 5 mm port for better depression or retraction of the posterior rectus sheath to achieve a crossover. While dividing the left PRS, we encountered again a pneumoperitoneum, but as said earlier, creation of space is the key. You can see the preperitoneal fat or the falciform ligament is very short. It is less than 5 cm in this patient. Continue to create the space and divide the right PRS. This was a case of robotic ETP Reustopas. All the fibrofatty tissue in the left retrorector space was cleared to define the seam of left PRS with the linea alba. This is a lateral 3-port technique similar to what we have published in laparoscopic approach. The left PRS was depressed and it is divided 5 mm from its junction to linea alba. So while dividing the left PRS, we encountered a pneumoperitoneum, but as said earlier, nothing to get panic. Trick is to continue dissection to achieve an enhanced space. The preperitoneal fat and the falciform ligament were depressed with the left hand fenestrated bipolar grasper. Continue dissecting the preperitoneal space to see the right PRS as appreciated by the marshmallow sign. You can see the pink rectus muscle through the translucent PRS. The right PRS is divided. So pneumoperitoneum won't hamper much if your concepts are clear while performing a crossover. Dissection and creation of the enhanced space is the key. Varus needle won't help in such pneumoperitoneum caused while entry or during a crossover. Two case scenarios where the patient had previous abdominal scars. Those are the three ports which are placed. The left PRS was already incised. Near the area of the scar, there will be extensive fibrosis. If you start doing crossover very higher up, you see the transverse muscle fibers there. These are actually transversus abdominis muscle fibers. So don't do a crossover very higher up. You need to see a vertical muscle fibers. In such cases of confusion, you incise the peritoneum, look from inside, have an intraperitoneal look. This gives an idea about where the right posterior rectus sheath is, where the right linear semitoris is, so that you can safely incise the right PRS, then achieve a crossover. You can divide right PRS intraperitoneally and then come higher up, what I call as a reverse crossover. You can see that those are the transverse abdominis muscle fibers which you would have divided if you have done a crossover very higher up. This is another case of Etep-Rs in a patient with upper abdominal scar. The left PRS was divided. The pneumoperitoneum is very common in such cases. Staying on the roof, dissecting more, creating more space is the key. You can see a lot of fibrosis in the preperitoneal space. Assessment of the linea alba and the right PRS is difficult in such cases. You have to take our time. In any doubt, incise the peritoneum, have a intraperitoneal look. You can see the right PRS as a marshmallow sign, then incise the right PRS to see the right rectus muscle. This was another difficult case with a patient with recurrent hernias who got operated 5 times earlier, 2 times open onlay mesh repair done. There was an early pneumoperitoneum during entry. As you all know by now that if there is an early pneumoperitoneum, space creation is the key. Here the patient had a wide divarication of recti, and whenever you are confused or have a doubt to identify the right PRS, have an intraperitoneal look. For that, incise the peritoneum, have an intraperitoneal look. This will give us the idea of where to incise the right PRS. So look from inside. Most of the times marshmallow sign may not be evident, and twitchings. Here you can see twitchings are seen on both, even on the linea alba as well as over the rectus muscle. So looking from inside, assessing the right PRS and then incising it to see the vertical muscle fibers of the rectus. So have a look from inside and incise the right PRS. This was another difficult case in a patient who has undergone Whipple's pancreatic duodenectomy and a right hemicolectomy for cancer of pancreas as well as colon. He had a large incisional hernia with bilateral inguinal hernia. So after creation of the left rectus spaces, you can see there is dense fibrosis in the PRS as well as in the preperitoneal space. So we have minimized the use of cautery here, expecting dense bowel adhesions in the PRS peritoneal complex. You can see because of increased fibrosis, it is very difficult to assess the planes. It is very difficult to assess where the PRS, where the transverse abdominis is, where the vertical muscle fibers of rectus are. So the planes were not clear. We were unsure about the planes. So whenever the planes are unclear or whenever we are unsure of where to incise the PRS, open the peritoneum, have an intraperitoneal view. We extended the right PRS cut inferiorly so that we can have a better intraperitoneal view. There are a lot of adhesions, as you can see. A look from inside defined the defect as well as the margins of the defect. We started following the margins of the defect. This is one of the trick to identify the right rectus muscle. So we incise the posterior rectus sheath at the margins of the defect, creating good space intraperitoneally. The sac was pulled with gentle external pressure. The continuity of the sac was maintained with the posterior rectus sheath, what we call as the peritoneal sac preservation technique. Then from the margin of the defect where the PRS was incised, the planes were followed higher up. So from intraperitoneally near the margin of the defect, we incised the right PRS and the plane was followed higher up to achieve a safe crossover. Performing ETP Reustopas for a recurrent hernia with history of previous IPOM plus repair is an extremely difficult task. We have published our work regarding this procedure in Journal of Minimal SS Surgery. The challenges encountered here are difficult retrorectus space creation itself because of increased fibrosis in the retrorectus space. The previous mesh would have crossed the linea similonaris because all the ports in ETP Reustopas has to be placed within linea similonaris, and if the previous mesh, transversal sutures and tacks would have been put beyond the linea similonaris, the space creation itself is a difficult task. We may expect dense adhesions of the posterior rectus sheath to the rectus muscle by previous transversal sutures and tacks. The falciform ligament would have been mobilized during previous IPOM plus repair to achieve good mesh coverage, and hence difficulty in crossover is expected. Early pneumoperitoneum is also expected. There might be presence of permanent transversal sutures and tacks, bowel adhesions to the mesh requiring meticulous adhesiolysis, and there are also chance of increased enterotomy during this procedure. There is also need for TAR as the PRS peritoneal complex will be fibrosed and thicken, preventing approximation without tension. So even for a smaller size defects, TAR might be required if you are planning ETP Reustopas for recurrence following previous IPOM plus repair, and hence there is requirement of a superior skill set. This is a case of a recurrent incisional hernia following a previous IPOM plus repair done for an epigastric hernia. You can see the presence of metal tacks over the left posterior rectus sheath. The left PRS was incised from the xiphisternum downwards. The preperitoneal space was extremely fibrosed. We can see the presence of previous composite mesh which was fixed to the posterior rectus sheath peritoneal complex. There was a linea breach. In such cases, having an intraperitoneal view, what I call as a look from inside, then cut the posterior rectus sheath peritoneal complex. This helps in achieving a crossover. This is another case of M2 incisional hernia following previous IPOM plus repair. You can see all the ports in previous IPOM plus were placed away from the linea similonaris, but whereas in ETP Reustopas, all the ports has to be within linea similonaris. NT was through the left costal margin. You can see the lot of fibrosis in the left retroctus space because of the fixation of the posterior rectus sheath to the rectus muscle. We could place a 5 mm port in the left lumbar region. Intraperitoneal view, we could see that the mesh was not fixed to the posterior rectus sheath. Probably it was fixed earlier with absorbable tackers, and the fixation had become loose and the whole mesh has fallen down from the posterior rectus sheath peritoneal complex, resulting in recurrence of hernia. Those are the previous transversal sutures. The left PRS was divided higher up. Then intraperitoneally all the adhesions of the bowel were lysed. Then the right retractor space was created. This is another case of recurrence following previous IPOM plus repair. You can see the presence of composite mesh which is fixed to the posterior rectus sheath on the left side. Multiple peritoneum rents and hemoperitoneum. It was very difficult to assess which is the posterior rectus sheath on the right side, whether it is a bare muscle or the PRS was already taken down or the marshmallow sign was confusing. With the assumption of marshmallow sign, we incised and encountered hernia breach. A look from inside helped us to assess the posterior rectus sheath on the right side. After incision, we could see vertical muscle fibers of the rectus muscle and the PRS was extremely thin. This was another case where a proline mesh was placed previously during an intraperitoneal onlay mesh repair and fixed with metallic tackers. This is a CT scan showing a metallic tackers which are used to fix the intraperitoneal proline mesh for an IPOM plus repair. So these cases are extremely difficult, as we all know that the bowel will be densely adherent to the polypropylene mesh. After defining the left retractor space, the left PRS was incised using a monopolar hook diathermy. You can see the presence of metallic tackers. We preferred using cold scissors, expecting dense bowel adhesions. Dissection was carried out at the roof, depressing the preperitoneal space. There was a peritoneal rent which encountered during a crossover. Intraperitoneal view was achieved through the peritoneal rent. We could define the crisscross fibers of linea alba. So whenever we are unsure about the right PRS, as mentioned earlier, have an intraperitoneal view. Those are the transverse muscle fibers. After assessment of the crisscross fibers, the divided left PRS, intraperitoneal view of the transverse muscle fibers, we could assess where the right PRS was, and incision was made to define the right rectus muscle. The PRS incision was extended upwards from the intraperitoneal incision to connect the both retrorectus spaces and thus achieving a safe crossover. Difficulty in crossover is also encountered when you miss the planes during entry. We all know that all ports in ETP eustopas has to be within linea semilunaris, and the primary or the camera port is the first thing which has to come within linea semilunaris. Here you can see the port was placed lateral to the linea semilunaris and the dissection was continued. There was an intraperitoneal entry. The mistake was not realized. The secondary ports were placed. There was pneumoperitoneum and the plane was also lateral to linea semilunaris. You can see the transverse muscle fibers. This is getting on the wrong plane. After it was realized, through the secondary port, The peritoneum was extended, intraperitoneal view was achieved. Then the left PRS was identified, junction to linea alba was defined. Then the PRS was incised or divided 5 mm from its junction to linea alba to define the preperitoneal space. And then the crossover was achieved after dividing the right PRS. Hope this video has helped the surgical community at large to perform crossover in ETP Stopers. Thank you all for watching. This is my team at Kaveri Hospital, Bangalore. It's Dr. Marina and Dr. Amol Jayur.